Okay, so we're going to move on to epilepsy in the condition series. So everyone has an idea about what seizures are, but I think the way to think about it is we have regulated, carefully controlled electronic impulses that allow us to think and function in terms of our brains. Seizures are a sort of uncontrolled paroxysmal discharge of the neurons of the brain, or a short circuit if you like, and that can be limited to one area of the brain and give you very distinct symptoms. It can be all over the brain, generalized, and that gives you a generalized convulsion or a generalized seizure in which you will be, the person will not be conscious, or it can start off in one area, be focal, and then generalize to the whole brain. We call the symptoms and signs that you get when the seizure starts in one particular part of the brain seizure semiology. So that allows us to diagnostically, with quite good accuracy, determine where the seizure started. And before we had sort of sophisticated imaging and neurophysiology, that was all you had. And that can be really useful if you're thinking about epilepsy surgery. And now we have things like telemetry, where we have people in for a period of time and we detect where seizures begin to see if, in theory, if medications aren't helping, whether we might resect or cut out a particular part of the brain if that won't cause too much damage to function to improve seizure frequency. People talk about auras and then they get mixed up between migraine and epilepsy, but the prodrome and the symptoms that people get around their seizures, you can call them aura if you like, it's part of the seizure. It's just if it starts in a particular part of the brain, that's the focal onset. It's not before the seizure if you like. The ictus is the seizure itself, however that presents, and then you get the post-ictal period where someone is no longer seizing but their brain is exhausted. The patient themselves are exhausted and maybe quite confused and agitated. We call that cerebral irritation. You know, the ambulance crew will come and say they got aggressive afterwards because they're just fighting them off and didn't really understand what was happening. That's post-ictal period. Some people can get post-ictal psychosis because they can be so confused and agitated after a seizure. But some people can have a really reduced GCS and may need ICU support afterwards. So more terms that are important to understand in epilepsy. So partial seizures, so we talk about which part of the brain that they originate in. We say simple partial. So for example, if you have a single arm focal seizure, the person might be aware that, oh, I'm having another seizure. And that's in the motor strip and it doesn't generalize anywhere else. And somebody remains aware, simple partial. Complex partial will be if that happened, but also the patient had an altered awareness and they were not unconscious, but clearly not present in the same way. And if you talk to them, they may give you odd or disorientated responses or no responses at all, but they're not unconscious. Partial with generalization, so somebody would have the arm focal seizure, and then it would spread to the rest of the brain, they would stiffen, and then they would have a generalized convulsion and be unconscious. So that's partial with generalization. And if somebody has generalized seizures, what used to be called tonic-clonic seizures, it affects the whole brain and they are unconscious by definition. There are forms of non-convulsive seizures, which are much rarer, where people just are less aware, and there might be very, very subtle physical signs, like sort of twitching of the mouth. We would see that more in sort of complex brain disorders and epilepsy syndromes, and you need an EEG to detect that really. So partial and focal seizures, we talk about them in terms of where they start. So temporal lobe seizures are the most common form of focal seizure, probably about 60 to 75% of all partial seizures, and it can present in loads of different ways. If you think that this is the sort of the memory bank of the brain, the memory storage area of the brain, so triggering different parts of that can bring about sort of different stimuli and give people very different symptoms, but it tends to be stereotyped in people, so people will tend to get the same thing again and again, which is helpful diagnostically. So it can be visceral, so people can get like butterflies in their tummy or a feeling of rising, we call that gustatory rising. Can get memory problems, so déjà vu, this has happened before, or jamais vu, this is unfamiliar, even though it's not. So I've done loads of these lectures, but if I had jamais vu, I would say to James, you know what, I feel like I've never done this before, but I've done this loads and loads, and that's jamais vu. Flashbacks, which is what it sounds like, and formed hallucination. So I have a patient who has never left the UK, but when he has his temporal lobe seizures, he sees a beautiful Japanese garden. He's never been to Japan. He has no interest in Japanese stuff. He described it to me, and I found a picture and said, look, is this what you see? And he said, yes, it is. So it's really interesting. He must have seen a picture of a Japanese garden before, and that's why he sees it. But strange that that's what he sees every time. It can be motor, so you can get sort of chewing, like chewing gum, or smacking of the lips, fiddling of the hands, we call it automatisms, or emotion. So some people get a feeling of elation, a feeling of dread, and there's something called an ineffable feeling. And some folks say that they feel like they're just on the cusp of a revelation, like they will understand everything. Just give me 1 second more, and then they have their seizure. And there are lots of discussions about what this means and what part of the brain is being stimulated. People with temporal lobe seizures may just have that, and it can last a few seconds to a minute or two, and then they recover, or it can generalise into a generalised convulsion. People often have headache afterwards and tiredness with their temporal lobe seizures. And if you've had seizures as a baby, fever seizures or febrile seizures, you're likely to get scarring of the temporal lobe and atrophy, and this forms a seizure scar. So an epileptogenic focus is the posh way we call that, an area of weakness in the temporal lobe which makes you prone to temporal lobe seizures. So this is a sort of coronal, is this a coronal? No, I think this is an axial, ignore me. But this is a close-up of a scan of somebody with mesial temporal sclerosis after febrile seizures. This is an adult. So on the left-hand side, you can see that it's much smaller and it's atrophied compared to the right. And this person has temporal lobe seizures as a consequence. So in the frontal lobe, if you have seizures which start in the frontal lobe, you can get Jacksonian march, where you get sort of a feeling of tingling that goes down the limb before you might have some movements. And that's a supplementary motor area. You can also get something called the fencer's posture, which I'll show you a picture here. So this is a baby in the fencer's posture. So the arm flexes and the other arm extends. It can be up or straight ahead, and the head tends to turn away. And there can be flexion of the arm as well. And that's a classical frontal lobe posture. And the extended arm is on the opposite side to where the seizure originates, and the flexion is on the same side, so the seizure will be starting here on the right side. And also the head and eyes deviate. It may just be the eyes turning, but usually the head. And if you see a child or a baby doing that again and again, stereotyped, that's a word we use in seizures a lot, you think this child may be having a frontal lobe seizure. If you get a seizure, there's a lot of detail here, you don't need to know any of that, but it's just quite interesting. Anterior cingulate, which is particular part of the brain, you might get hyperkinetic movement, so a sort of rapid jerky movement, which is unusual. And there's a part of the brain called the frontal opiculum, and you get very strange things there, facial movements, drooling, and speech. You can get speech arrest as well. So much less common, seizures originating in the parietal or occipital lobe. So parietal lobe is less than 5%. We don't know whether that's because it's so strange and people may not articulate it or even realise they're having a seizure, or it's just rare. But it's less than 5% of all epilepsies. And people, so if you remember, the parietal lobe kind of determines where you are in space and how you interact with your environment and perceiving your environment. You get distortion of that. So we sometimes call it Alice in Wonderland syndrome. So you suddenly feel that your hands are enormous, or the road in front of you is sort of bending upwards, or you're very tiny and everything else is very big. And you can see when Alice in Wonderland, you know, she got big, she got small, eat me, drink me. The doors were suddenly tiny, the doors were enormous, she had one big foot. So that's what parietal lobe seizures manifest as. They can be associated with temporal lobe seizures if you have sort of scarring that extends into the parietal lobe, but it's extremely strange and kind of it depicts to us all the things that the parietal lobe does, because when it doesn't work, you then see what manifests. Occipital lobe, so remember your occipital lobe, you see with your occipital lobe, the light goes into your eyes, but it's processed in the occipital lobe. You can get some oculomotor features like sort of blinking or your eyes moving, but typically you get coarse, basic images, and usually people talk about balls of coloured light, and they always say it looks like Christmas lights. So you tend to get formed hallucinations with the temporal lobe, and I think that's tapping into a memory of an image, whereas stimulating the actual visual receptors themselves gives you just sort of like coarse images, like balls of coloured light. So I will mention otoscopy because it's very strange, because occipital lobe seizures, you can get otoscopy where you feel like you're outside your body. I've never heard of anyone say that, but I always ask about it because it's cool. So workup, so you need good history, essential. You need examination, often you won't find anything, and you need collateral history, because the classic thing is, when the doctor is asking the patient what happened during a seizure, there are two people that were not present, because usually, unless it's a simple partial seizure, the patient doesn't know what happened. So you need somebody there who has seen it, ideally. Otherwise, you can never have true clarity. You need to do an ECG, particularly if somebody's just had a blackout or a collapse and you don't know why, because if it's cardiac, that's life-threatening. And if they go through the sort of neurology path, they don't get assessed and treated for their cardiac conduction problem and may die of it in the interim. Imaging, so if somebody's having a protracted seizure and you don't know why, CT, they may have encephalitis, they may have a tumour. If they're having a brief seizure and they're well, they might have an outpatient MRI, and it would look for things like temporal lobe atrophy if they're having typical temporal lobe seizures, for example. And there are factors affecting which anticonvulsants you use. So in a young woman, you would avoid anticonvulsants that might have an effect on pregnancy if she wants to have a child. Some anticonvulsants make you put on weight, and if somebody has a problem with that, you would try and choose other agents. Psychiatric history, there are some medications that can worsen depression. And we always weigh up risks, benefits, and individual needs, and there have been lots of studies done, but the best one probably is called SANAD and SANAD-2. Cut to the chase, lamotrigine is excellent. So lamotrigine, disadvantages, it's processed by the liver, so if there are liver problems, that can be an issue. It's very slow to build up, it takes about 6 weeks to get it therapeutic. So if somebody's having lots of seizures and you need to get on top of them quickly, lamotrigine is probably not the best one, first line. But it's excellent for generalized seizures, it's excellent for partial or focal seizures. It can have a stabilizing effect on mood, it doesn't tend to make you fat. And it's the best tolerated of most of the drugs. So in summary, lots and lots of different types of seizure types. The area of the brain it originates in can give you a clue. So temporal lobe, you can get funny smells, funny visceral or stomach symptoms, funny movements. Frontal, you get postures, funny movements. They can come about from sleep and be very rapid. Parietal, there's Alice in Wonderland distortions. Occipital, just simple flashing lights. Always try and make sure that what you're being told about is a seizure. Collateral history is very important. Recordings on phones now can be really helpful. Lots of people are treated for a simple faint with a couple of jerks over half a second and they don't have epilepsy. So recordings on phones now, super helpful. History and examination allows you to lateralize. Video telemetry allows you to capture seizures in a controlled environment. And it may be that in complex epilepsy, seizure surgery might be helpful, and it's all about selecting the right patients.